So today we'll go over why knowing hamstring anatomy can help with a foot drop workup. We will go over a quick review of the most common cause, which is a lesion at or about the fibular head. So the hamstring muscles are the biceps femoris, the semimembranosus, and semitendinosus. The biceps femoris has a long and a short head. The most important thing to know is that the short head gets innervation from the common perineal division of the sciatic nerve. Not the common perineal nerve, but the division of the sciatic nerve that will eventually become the common perineal nerve. The others are all tibial nerve, and also the long head, semimembranosus, and tendinosus all cross the hip joint. So if you're working out, you need to do hip extension exercises in addition to knee flexion exercises to maximally stimulate the hamstrings for growth and development. So if a person comes to your clinic with foot drop, so that's inability to dorsiflex or bring the foot up, or evert, bring the foot out, then there's going to be a lesion somewhere along the common perineal nerve pathway. If there is only lack of dorsiflexion, then the deep perineal branch is going to be affected while the superficial perineal nerve will not be affected. Therefore, you must think that the common perineal and everything above is going to be intact, except for possibly an L5 radiculopathy. Otherwise, both of these would be abnormal if the common perineal or anything above was affected. So in this case, we're going to say that both of these are affected. So the patient cannot dorsiflex, so the deep perineal, or evert, the superficial perineal or fibular nerve is affected. So an important thing is to figure out if this is a pre or post ganglionic lesion, so pre or post, and that's going to pertain to the radiculopathy component. So we need to try to rule that out or get an idea of if there is one. So when you're talking about pre or post, you're referring to the dorsal root ganglion. And so if there's a lesion pre or before the dorsal root ganglion, that's usually going to be a radiculopathy because that's where most nerve root impingements occur. This is very important because anything that's pre-ganglionic will not get picked up on a sensory nerve conduction study. So a person could have a completely numb leg, yet if their lesion is pre-ganglionic, their nerve conduction study would be completely normal because the signal is going to the dorsal root ganglion and back. And so because it doesn't get a chance to go past this lesion, that's why it's normal on a nerve conduction study. So the sensory studies, the superficial perineal is very important. If that is normal, then you're already thinking it's most likely going to be a L5 radiculopathy. Of course, you're going to do other workup. But let's say this is abnormal, and then these everter muscles are abnormal, and these dorsiflexor muscles are abnormal. So now we're thinking it's either a common perineal nerve injury, a sciatic nerve injury, lumbosacral plexus nerve injury, not an L5 radiculopathy because this sensory study was abnormal. So we're thinking here, sciatic nerve here, or lumbosacral plexus here. So you're going to needle certain muscles. We're going to needle the tibialis anterior, the perineal longus, the extensor digitorum. So these are all muscles that come off the common perineal nerve, and so they're all going to be abnormal. That doesn't really help us much, except to know that it's not going to be either one of these two, but both of these. So that's where knowing the short head of the biceps femoris is innervated by the common perineal division of the sciatic nerve. So right here comes into play. If we needle this short head and it's normal, then we know this is okay. So we know the sciatic nerve is okay. And so therefore the lesion has to be between here and here, which correlates to at or about the fibular head. You would also needle the lateral gastroc, possibly the posterior tibialis, to cover the tibial muscles, and therefore the tibial division of the sciatic nerve is also intact, so you can confirm the sciatic nerve is okay and everything above is okay. It also helps to know, or you must know, the nerve roots and the peripheral nerves of each of these muscles to put the pieces of the puzzle together. So posterior tibialis is L5, S1, tibial nerve, lateral gastroc, L5, S1, tibial nerve, tibialis anterior, L4, L5, deep perineal and common perineal, extensor digitorum, L4, L5, S1. The perineal longus or fibularis longus is going to be L4, sometimes L5 and S1, superficial perineal nerve. So, what do these mostly all have in common? L5 nerve roots, yet different nerves, so there can't be any overlap. So, that just helps you with the radiculopathy workup. So, if this was abnormal, this was abnormal, this was abnormal, most likely you're not going to have an injury of each of these specific muscles. You're going to see what's the common denominator. That's going to be your L5 nerve root. So most likely an L5 radiculopathy, but you need to put that together with having a normal sensory nerve conduction study, which we talked about earlier. To rule out the lumbosacral plexus, you would probably do a glute max, superior gluteal nerve, and that is L4, L5, S1. Again, the L5 common denominator there. That is a quick rundown of how knowing hamstring anatomy can help you with a foot drop workup. Since we did our hamstring workout yesterday, we thought we would tie it in together today with this quick little mini lecture.